We are rolling. All right, thanks for everyone for joining us today. Today we have Mike Hatch, Director of Crisis Services for the Mental Health Association of the Southern Tier, as well as Sergeant Alex Legos Williams, who's the CIT coordinator for the city of Binghamton. And just as kind of a precursor here, in 2020, the Binghamton Police were one of only 5 law enforcement agencies in New York State to complete a One Mind campaign with the Association of Chiefs of Police, which requires law enforcement agencies to implement practices to improve police response to mental health calls. I know that they'll go over this a little bit more in detail about what the One Mind campaign is and the existing crisis intervention team training that happens in the city of Binghamton. But for example, 100% of sworn officers are trained and certified in mental health first aid, and more than 20% of officers are trained and certified in crisis intervention team training. Mike and Alex work together to improve and train Binghamton police officers. And with that, I will give them the floor.
Thanks, Jared. So as the deputy mayor said, my name's Mike Hatch. We're wearing our masks because we're not able to social distance right now, but I'm the Director of Crisis Services for the Mental Health Association of the Southern Tier, where I oversee the crisis intervention team coordination and training for Broome County. I also supervise the mobile crisis team that I'll talk a little bit more about in this presentation. And I also oversee the Crisis Respite House, which is a 24/7 crisis respite program that we have right in the city of Binghamton at 295 Clinton Street. Alex?
Hi, I'm Alexander Legos Williams, a sergeant with the Binghamton Police. I've been a police officer for about 10 years, sergeant since August, and I took up this position as CIT coordinator in September of 2020.
And I'll also add that I am a retired police lieutenant from the Johnson City Police Department. I had 23 years of law enforcement experience and retired in 2016 from JC to take the position that I'm in now. So we're going to kind of go over some of the things that we've already accomplished and maybe some of the things that are futuristic ideas that we have to maybe enhance crisis response. The deputy mayor had mentioned that a lot of the questions that the committee has received have to do with mental health response and mental health training and things like that. So they felt that it was important to kind of showcase some of the things that they've already done in the city of Binghamton. And I could tell you from experiences in the community, the city of Binghamton Police Department, their training in mental health and response far exceeds many of our partner organizations in Broome County, let alone the region. So some of the goals, CIT stands for Crisis Intervention Team. It does not stand for training. The number one goal of CIT is to transform the crisis response system to try to minimize the times that law enforcement have to actually respond to people in emotional distress. The second goal of that is to provide the police and the first responders with the knowledge and the tools and resources to assist when they do have to go on those situations and help try to de-escalate it, divert those individuals from the criminal justice field is the priority. We're going to focus primarily on transforming the crisis response system and showcase some of the trainings and things that we've already done. This process started way back in 2015 with what's called sequential intercept mapping, where we had consultants come in and they kind of went through the process of crisis response with us and what resources we have and where we can improve on some of those resources. Typically for law enforcement, we look at Intercept 0 and Intercept 1. That's kind of where everything starts. The crisis or the incident happens. The crisis lines are involved at Intercept 0, and you can see 911 and law enforcement kind of overlap between those two intercepts. The reason is because they can come in at an early phase, during those crisis situations. One of the focuses, or the biggest focus, is in Broome County was that we looked at, is there an opportunity to divert those calls directly from 911 to those crisis lines, or involve the crisis care continuum, which is a piece of that in Broome County is our mobile crisis response team. And then is there an opportunity for local law enforcement to divert from arrest and even divert from hospitalization and revert back to that crisis response team? And we've been very successful with that, particularly in the city of Binghamton. The current state of the mobile crisis team, we have the Director of Crisis Services, is my position that oversees these programs. Right now we have one licensed clinical social worker, and we do have a vacant position for a second one to put on a second shift. We also utilize certified, New York State certified peers as case managers to assist those clinicians. And we have a vacant position open. So we're looking to expand the program, which is already funded. That's funded through pass-through money from the State Office of Mental Health to Broome County Mental Health, and they provide the funding to the Mental Health Association to provide these services for the community. And we deliver this service through partnerships with Broome County Emergency Services, and our local law enforcement are our key partners in this. And that service provides an on-demand service to try to de-escalate situations and avoid hospitalizations and diversions from jail, and assist the police officers in any way they can. Mobile Crisis was launched in 2016, and it provides that on-demand. We like to say we like to meet people where they're at. We like to meet them in the community and try to avoid any sort of traumatization where they may have to be taken in a police car to the hospital, which can be very traumatic for an individual to have to interact with law enforcement in that way. So if we can avoid that, we make every effort to do that. And as you can see by our numbers in 2020, we were very successful in doing that. The mobile crisis, which at the time was a mighty team of the one person you see on here, Sandra Westgate, responded to more than 250 initial crisis calls. And our peer response did 170 follow-ups just on those 250. The statistic of more than 75% of those 250 calls were stabilized in the field, meaning they did not have to go to the hospital. And the police officers could stand by, make sure that Sandra and our peer support person were all set, and then they could clear the scene. And then the call was passed off to mobile crisis. It's been a very successful model, and we're looking to expand on that model as much as we can. The Mental Health Association of the Southern Tier has current partnerships with the Binghamton Police Department, the Broome County Sheriff's Office, Johnson City, and Vestal Police. We have a business association agreement with the Binghamton Police to assist them through all of this, all these collaborative efforts that we're talking about today. And what these police departments do is they actually provide Binghamton Police records, actually keeps a separate file of all the mental health complaints that come into the city. And we pick those reports up typically 2 or 3 times a week. And we go through those police reports, and the mobile crisis team are assigned to follow up on individuals that after reading the report is either requested by the police officer to go and check on that person and follow up and provide services, or we'll read through the reports and say, geez, this person may benefit from outreach. Let's see what we can do to help them out. And we've had great success with doing that. And we do that with all of these police agencies that you see listed here. Through these partnerships, we collaborate with people like Sergeant Lagos Williams. Prior to him, his predecessor, Sergeant Tony Dials. We collaborate to provide and develop trainings for our police partners in what they could benefit from mental health training. So these are just some of the examples of organizations that we've trained for in our law enforcement community. We do the in-service trainings for the Broome County Sheriff's Office, the Binghamton or the Broome County Police Academy, the Police Supervisor School. We do that for corrections and road patrol. And for the Binghamton Police Department, as Jared mentioned, the International Associations of Chiefs of Police One Mind campaign is where police agencies take a pledge to train at least 20% of their entire sworn police members in the 40-hour CIT training class. And additionally, they agreed to train the other 80% in mental health first aid, which is an 8-hour training class. And I can say that, the city of Binghamton Police Department has done a phenomenal job with implementing that and completing that in about a 9-month turnaround, I think is the time that we actually completed that entire program. And the sergeant and I actually looked at the numbers right before this, and I think we were right just under 40%. So 40% of the entire sworn Binghamton Police Department has been trained in the CIT 40-hour training class, which is a phenomenal number for the city of Binghamton to have that many officers trained in the CIT training. So kudos to them for doing that. So, and additionally, the mental health first aid class, all of the other officers received that training, which was delivered by a core group of instructors right here in our community. We've done training for the district attorney's office. We actually developed a specific CIT training course for school resource officers. And the Binghamton school resource officers actually attended that training as well. And then we do training for emergency services, 911 dispatchers. We have a 911 diversion program right here in Broome County. It's the first of its kind in the entire state of New York, and it is being replicated across the country. And is even listed as a best practices model in the CIT International Guide for CIT implementation. Let's see, provide 40 CIT training police. So yeah, so the CIT training that we've done it for police, corrections, and we've had 911 dispatchers actually sit through that entire 40-hour training course as well. And mind you, this is over, this is since 2016, we've actually been doing all these trainings and things, and we continue to do them on an annual basis or when requested. So that's kind of like where we're at today. And what, our mindset with the Mental Health Association is trying to enhance the crisis response system. And, our thoughts of doing that is working off our current 911 diversion model, where our 911 dispatchers have a risk assessment tool that they've been trained on and we provided them. And if the person fits the criteria, that call can be transferred to the crisis call center at CPEP, or the Comprehensive Psychiatric Emergency Program that is at Binghamton General Hospital. So our hopes are that, we can find ways to use shared services and maybe work together with some organizations like the city of Binghamton and perhaps the county to develop a co-responder model where we actually have a trained sworn police officer that is assigned to one of our existing clinicians, and they can actually be dispatched directly to the call and handle that crisis call and completely, in a sense, remove the police officers in that current zone or sector or whatever you may have, that they don't have to respond to that call because it's being handled by a crisis response unit. They can provide secondary backup if it's needed or things like that. But our hopes are to try to take this model and really go to the next level with it and really provide a true diversion model with a true response to meet people where they're at. There's some costs involved, of course, and a lot of these costs are already paid for through the funding that we have for the crisis. So to implement something like this, it would probably cost, depending on how you did it. If you did a sworn police officer, it's about $125,000 to put a specific person or police officer in that. If you utilize somebody like a district attorney investigator, a special.
I just got on my emails. It was started at 1:30.
So if you did something like that, it cuts the cost nearly in half. So you're looking at either $120,000 to do something like this through the DA's office or a special deputy or something along those lines, or special police officer if it's even allowed, versus $180,000 to actually fund and implement something like this. The benefits of doing something like this. Medicaid is a huge cost for all of us in the state of New York. So not only is it the right thing to do for our community, and it gives them a special response where somebody has the training and the ability to spend the time with that person to de-escalate them and connect them with the services they may need. But the cost savings alone of doing something like this can be very significant. These are just numbers that we looked at initially. So if somebody goes to the hospital and they're a Medicaid recipient, you have a bill for Medicaid for the comprehensive psychiatric emergency program. It's $1,095. And then you may have ancillary costs on top of that. So you're looking at around $2,100 in a bill for somebody that has to go to a hospital. And we kind of broke those numbers down by agency. The City of Binghamton Police Department responds to 40% of all the mental health calls in Broome County. And across the board, that's just over 2,000 calls a year. 40% of those happen right in the city of Binghamton. So if you average those out, Binghamton Police responds to about 72 calls a month that are labeled as mental health. Alex and I will agree that we believe the numbers are much higher than that on what mental health calls are. These are just the ones that get labeled as mental health calls in the system. So if you do the math on that, where you have a specific unit that responds to just 25% of those calls, and then you do further, you break that down further and say, let's say they're successful 68% of the time, as opposed to 75, which our numbers actually are. So we lowered the number a little bit and said, let's say they're successful 68% of the time. The Medicaid cost savings is $25,000 a month on something along those lines. Now, I get it and acknowledge that, the county has a cap on Medicaid, but if you look at the big picture across the state and federal savings and everything else, you would hope at some point, there would be some sort of benefit or return on that, because you're looking at savings across the board, not just looking at county Medicaid savings. Once that cap's met, the county doesn't have to pay anymore. So that's just one of the examples of the potential cost savings, let alone the opportunity to provide somebody a service and potentially provide less trauma to that individual that may be going through that crisis. And that's kind of it. The road is really just refine the roadmap, figure out what the best the best options are for us, and maybe look at some shared services through either the county and the Binghamton and the city of Binghamton in a collaborative partnership, and then just improve that mental health response system. So that's our shtick, and we'll certainly be glad to answer any questions or anything that we can help with. We're here.
Mike, thank you for that. This is Megan Brockett from Mayor David's office. Jared just stepped out. I believe he had another meeting. He should be back. But if it's okay with you and the sergeant, if we could just open it up to questions from members of the steering committee, if anyone has them.
Absolutely.
Hello, Michael Hatch. This is Reverend Mario Williams. How are you guys doing today?
Good, how are you?
All right, doing well, thank you. You may have answered this question already. I'm not really sure. But when there's a call made to dispatch the police force and the CERT team, who makes a determination that there's a crisis there for if it's mental health or if it's a crime? Because there were some concerns in the community about certain individuals being arrested that were having a crisis and they felt that intervention should have been done by the mental health team. However, there's a debate about the role of the police officers responding and taking the situation, getting the situation under control first, and then making that determination. So I guess my question is, when a call comes in, who makes that determination that it's a crisis, a mental health crisis? Sometimes you get a call and the parents are requesting the police officers to come out. So that's my question, I guess.
Okay, sir. Anytime that the police or 911 gets a phone call about a mental health issue, the 911 dispatchers take that call, they assess what the threat level is and where it's located, and then they'll usually send out the police department first. to determine if any kind of crime did take place and what is occurring. If they determine that it's a mental health issue, they'll determine if the person is a threat to themselves or others. And if the mobile crisis team is available, we will call them and have them respond with us. And then they will make that determination. We'll kind of stand by as just for safety purposes and nothing other than that. You're still muted, Mario.
Thank you. Thank you very much. I appreciate it.
So Mike, I just wanted to jump in real quick and thank you for the presentation. MHAST has been a great partner for the city of Binghamton. As you know, we entered into an agreement much earlier this year to expand services and support provided by the Binghamton Police Department. And with the support of City Council, we recently allocated an additional $50,000 just as a starting point, and are willing and interested in expanding that to try to figure out ways where we can expand coverage. As you indicated in the very beginning, you had a vacancy on one of your shifts, and we're obviously very interested in looking at this from a more holistic standpoint, as far as, you know, weekdays, weekends, daytime, nighttime, where the volume of calls seem to be, are they equally distributed? Are they occurring more on weekends versus weekdays, nighttime, et cetera? And are certainly interested in working with MHAST to expand the range of services that we have. And I just think it's important to note that, you know, long before this executive order came from the governor, we were having these conversations. And I think it's important for the panel and the community to know that part of the annual reflection that the police department does and how to increase their level of service. This was an area that was focused on and continues to be focused on as a result of just evaluating the data on the types of calls on an annual basis. That's something that is just, you know, really routine. I think the timing of it is very good, and I think there are some different scenarios and models. Obviously, as you indicated in your presentation, a high percentage of these calls come from the city of Binghamton. And, you know, with the closure of some of the state facilities that focus on, you know, mental health, a lot of these services fall on the shoulders of teachers and police officers and other sorts of public servants in our community, pastors, et cetera. And so it's not just about, you know, additional training, which is very important. Obviously, training is central and critical, but also enlisting the support, whether it's through hiring individuals directly or partnering with organizations like MHAST directly, who have the personnel who specialize in this, are trained in this, to partner and accompany, you know, officers on call. And that's something that we want to look to continue to expand on in the future. So I just wanted to, you know, highlight that. You and your team came to City Hall, I think it was over the summer now, where we highlighted that partnership and the expansion of that money. And I know that we're finalizing that plan as we speak. And if we need to invest additional resources in that area, I just, you know, want everybody to know that the city is more than willing to do that. But we need to have a starting point somewhere and work on a plan that's well. And I know that City Council supported that allocation of funding as well.
I appreciate that, Mayor. And, you know, I'll add that, you know, through, you know, the mental health first aid trainings for adults in public safety that we've done just over the past few years with grant funding and no cost to taxpayers, we've trained over 450 members of our community and first responders and people from churches that are interested in this. Because as you said, some of this falls on our faith-based folks like Mario. And, you know, we've had a lot of our church committees come through some of our mental health first aid classes. So, you know, we're on board. We're here in the community, and we're here to, you know, assist through this process. And as you mentioned, you know, we've been transforming the crisis response system has been on our radar for at least the past 6 years. And we've been working on it and progressively working towards, you know, where we're at today and where is tomorrow going to lead us to. So.
Yes, hi, Michael. This is Reverend Williams again. How many African-American pastors or leaders, community leaders, have been invited or have participated in the training that's been offered, and how does one get involved? Because I'm not really aware that that training was available
Yeah.
to clergy.
I don't have a specific number for you on that. And I'm just, even off the top of my head, I wouldn't even want to give you a number, but I can certainly make sure that you have the contact information with the right people, Mario, after this meeting, and I can hook you up with the people that set those trainings up. I mean, they've kind of stalled during COVID right now, but post COVID, once we're past this next hurdle there, I think those trainings will ramp right back up. But I'd be glad to put you in contact with the person that organizes those trainings for us.
I appreciate that. Thank you.
I think Karen had a question.
I did, thank you. I missed the very beginning of the meeting. I was on another Zoom meeting with work. I had a question because you mentioned you currently have one counselor, with a master's in social work, and that you want to add an additional one. And I think you said you had funding for it. But you also, I think, mentioned that this would only cover like Monday through Friday. And I thought it was 12 hours a day. I'm just wondering, because it seemed like this was a really big concern with a lot of the people in the last few meetings. What would be or could be the solution for the odd hours, or is there one? I know this is no easy fix, but I just think that this question will probably come up.
I think the plan is, I think the plan is 15 hours a day, and it's probably going to be just to start and pilot it Monday through Friday, 15 hours a day. So we'd have the day shift and the afternoon shift covered. I have studied the crisis numbers inside, outside, left and right and up and down, and there's no rhyme or reason to them at all. Just looking at the numbers, the one thing I learned from that is that crisis has no calendar. And there's really no specific day of the week that you can point to that says you should have maximum coverage on Saturdays because of this. It just doesn't work that way. So that's the one thing that I learned, is that crisis doesn't follow a calendar, and it's kind of it's unpredictable, because what causes me to have a crisis may not cause somebody else to have that same issue. So it's really unpredictable. So our hopes are that we had an afternoon shift pre-COVID. That typically was our busiest time, was during those afternoon hours. So we're hoping that covering the daytime, where a lot of the community-based organizations are open and we can get in the door and get referrals to, and then enhance that by offering those afternoon hours, at least starting 5 days a week. I really think that it's a program that needs to be built on. And it has measured success with, 75% of the people they see stabilized where they're at is so important. And to be able to relieve the police officers of actually having to go on those. And there's a lot of myth around mental health response and mental health calls. A person with a mental illness is more likely to be a victim of a crime as they are to be violent. So there's a lot of myth around, mental health response when you talk about that. In Broome County, we had over 2,000 mental health calls, and you probably, you might have heard of a handful of them in the news media and things like that. But, to put that into perspective, I would never say that there's never a level of dangerousness, because there always is. And we want to make sure everybody's safe and protected as best as we can. But I also want to make sure that when we discuss mental health or mental crisis or distressed caller, the level or the threat level of dangerousness is not commonly high.
Okay, thank you.
Hi, it's Joe Burns.
Hey, Joe, how's it going?
Good. Thank you both for being here. It's a lot of great information. And I gotta say, I don't believe that the public has this information, and I'm gonna do my part to get it out there to everybody. I'm interested in the last model that you had on there, where you were talking about we could collect from Medicaid. Is that only if we go ahead with hiring our own person for that category that you were talking about? And also, if we did go that way, I assume private insurance, if somebody has private insurance, we could also collect with private insurance. Is that correct?
That it's not actually. We're not. So you have to be designated by the State Office of Mental Health to provide these services. And MHAST has the crisis continuum designation in Broome County is through MHAST to provide these services. The cost savings comes in where MHAST has the ability to bill only managed Medicaid organizations for that service. And the cost that we bill is much less than what the hospital bills. So if you go to the hospital, and I'll take just that component of a bill for the comprehensive psychiatric emergency program. So if a person goes to CPEP, the Medicaid bill for that is $1,095. The Mental Health Association bills only community or only managed Medicaid. So they have to be signed up for with managed Medicaid. We cannot bill private insurance or any of that. And we don't bill people that don't have insurance. So only managed Medicaid. And we bill that at $109 per unit, which is a unit is 15 minutes. So you're talking about a significant, less cost for somebody to respond from a community-based organization that has the designation to provide this service, as opposed to hospitalization.
Mhm. Okay, so the city can't get back any money then, if the city's providing services.
Yeah, I mean, you'd have to talk to your finance people about Medicaid and how much the city, and that might be a question for the mayor or Jared even, but how much the city has to pay towards Medicaid. I don't know those numbers. I'm not sure. I mean, I know those numbers are capped for the county. So, as far as, actual, savings to the city, that would be a question I would refer to them or the finance folks.
Okay. Then also a question about, I know that after 11 p.m., we don't have any coverage until morning. And what would it take to get coverage for that time?
The one thing that we've found through looking at the numbers and the data and things is that a lot of times what happens in those after hours is the individuals in crisis have substances on board. So from the perspective of a mental health clinician, it's very difficult for them to say this is either substance induced or this is an actual mental illness situation. So the one thing that, and we've actually had discussions with the State Office of Mental Health about this, is it's very, number one, it's difficult to find licensed clinicians that are interested in this type of work and want to do this work. But the reality is finding somebody to do those after hours, 11A to 7P, can be very challenging to do that. And the fact that, typically with those substances on board, it's very difficult for a mental health clinician to actually hash that out and, make a determination whether it's mental health or substance induced.
Mm-hmm. Okay, and our CIT officers still, even though the mental health isn't available after 11 o'clock, they're still trained to take somebody having a mental breakdown of some sort, to then take them over to the general hospital, to that unit over there, even in the middle of the night?
Yep, that's what we're trained to do. We, we assess how much they're in need of that asset, and then if they are in need, then we take them right over.
Okay. All right, thank you.
Can I follow up on Councilman Burns' question?
Yes.
Okay, thank you very much. First of all, I think the presentation was very helpful. And as Councilman Burns said, the public is not aware of the training that the police have had in this regard. And I think it's important for us to educate them in that regard. My question is about the CPAP follow-up. When you take someone to CPAP, you make a determination that they need help or services. How often does CPAP retain those people, or do you find yourself dealing with them again?
I don't have an exact number, so I can tell you that the level it takes for an officer to transport somebody to the hospital is much less than what it is to admit them to the hospital. So,
Okay.
So typically when you have a situation in the field, a police officer makes a determination of danger to self or others and appears to have a mental illness. Those are the two criteria for mental health law 941. So that criteria, the threshold to take somebody and take them or transport them to the hospital is low, and it's set that way for that reason. Once they get to the hospital has to determine that the person, the level of threat, dangerous to self or others, and has a mental illness, and it's currently acute, where it's actually happening now. Now, one thing that we find, and I found as a police officer, and I'm sure the sergeant can agree, is that sometimes when a person goes to the hospital, the wait time may be, 5, 6, 7, 10 hours waiting at a hospital to be, evaluated. What happens over time is that crisis de-escalates, and the person may not be in the same mindset that they came in as they are in that wait time. So crisis de-escalates over time. And when, the hospital does their evaluation on them at the, the end of the wait, whatever that may be, the answers to the questions are certainly not the same as when they came in. I was angry, I was mad, I said I wanted to kill myself because of this, this, and this, and I don't feel that way anymore. So they leave the hospital, they get signed out. So that's, kind of where, where it's at with hospitalization. The percentage of people that actually get hospitalized, I don't have an actual number, but I can guess that it's low, as actual people that were admitted from being taken by law enforcement to the hospital. And that's probably a number that I could reach out to some contacts and get, but I would guess that number is significantly low, a low percentage. The numbers where our clinicians take them to the hospital is much higher, because they have that licensure, and the clinicians have to determine, the clinicians have to have the same criteria as the hospital does in order to write a piece of paper called a 945, where the police can take them to the hospital based on the observations of that clinician. So that threshold's much higher than the police threshold, but the numbers, and that's where a lot of the frustration comes, where an individual's taken to the hospital, and sometimes before the
They're not admitted.
they're walking out. And that's because the crisis has changed, and it's no longer acute, it's no longer active, it's no longer happening. And our state laws just simply don't allow us to, keep people against their wills for those reasons. I mean, we don't want to violate anybody's rights.
All right. And is there follow-up after that if they're not admitted to the hospital?
Yeah.
Is that what you mentioned earlier?
Yeah. Once they leave CPEP, they leave there with an appointment to a mental health clinic, or they leave there with the opportunity to get an appointment within 5 days of leaving the hospital. What we do for the individuals, if our team goes out and sees them, we have New York State certified peers that are partners with our clinicians. Those New York State certified peers actually attach themselves to that person in crisis, and they can stay with them and follow up with them for 15 days after that initial crisis.
Okay.
So and we're able to provide that service. And then if they have another crisis, then that clock starts over, and they can be seen for another 15 days. So we typically utilize the peer supports to reach out to them, go over a needs assessment with them, maybe what they need, what caused you to get into that crisis? What can we do to prevent that from happening again? What services do you need that we can help you get set up within the community? Sometimes transportation is a barrier. Our peer support people will transport them to go get their medications. They'll take them to the hospitals or doctor's appointments or whatever they need, or they may even rise to the level of needing to stay at our crisis respite house, and we'll actually transport them over there, and they can stay there for an extended period of time now to provide further peer support services 24 hours a day, 7 days a week.
Great. Okay, thank you very much. I appreciate the information.
I have one more question, if you don't mind. And I don't mean to put you on the spot or anything like that, anywhere, any close to that. But the people that I talk to, they're upset about these things that they see on the national news. And the two that come to mind are that happened in Rochester. The one where the man was having a breakdown. He was naked. They put a bag on his head and they lay him down and in the snow, and it's snowing and nobody's covering him up. and the other one is the little girl who was handcuffed and was pepper sprayed. The training that we have in Binghamton could, I can't say could it happen, but what would our training be that might be different than what occurred in those instances?
Well, we're doing the training right now. It's mostly in recognizing that there is a mental health episode and then getting that mental health treatment as soon as possible and as humanely as possible. Because we obviously know that something like that shouldn't happen. And we're taking steps in order to stop that from happening. Just telling guys, hey, this is a mental health episode. This person needs mental health treatment as quick as possible, and they need an ambulance at that point is a huge factor. And we're all getting that training. We get it yearly in the in-service, and I'm reaching out to get more training for more officers.
Yeah, one of the things to highlight too is that through one of our partners, which is an organization called Care Compass Network, in the Mental Health Association and the Binghamton Police Department, actually collaborated together to, and our officers in Binghamton are actually going through this training right now. Binghamton and Johnson City together is a trauma-informed response training. So right now in-service training, they're getting a 2-hour block on what it means to be trauma-informed and what sort of response you should have to somebody that's in a traumatic situation. Understanding trauma and being trauma-informed is half the battle when you walk into a call or an incident, and having, just having a good understanding that you don't know this person's story. It's likely that there's some sort of trauma that happened to them to get them to where they are today in this crisis. And we're providing that training right now through the end of March for all of the police officers in the city of Binghamton and Johnson City are receiving that training right now.
That's great. That's great. Thank you.
Yes, I have another question. Does anybody have actual numbers of how many calls that were being received for mental breakdowns or criminal activities? There's comparison. Is there more calls for the Binghamton Police Department for mental crisis or criminal activity in our community?
I mean, I would say that, I don't have the exact numbers. I think that's, probably something in the chief's office that you could probably get and access. But I can say that of the 2,000 mental health calls, 40% of those happen in the city of Binghamton. But I would take an educated guess and say that, checking the numbers with the chief's office would probably say your crime numbers are considerably higher than your mental health numbers.
Yeah, the reason for that comment there was I wanted to see if the burden of the mental health crisis was shifted over to the Binghamton Police Department, or is it working with the intervention team? Since you developed an intervention team, it's really kind of reduced some of that burden off of the police department.
I think so. The current model, the police still go on the calls with those mobile crisis clinicians. So the police are still involved in those calls, but I think that the model that we demonstrated towards the end of the presentation could almost allow those patrols in those certain areas to continue to provide the community service and protection for the city of Binghamton while those mental health calls are being diverted and handled by a specialized unit. And I really think that, this is, the councilman mentioned, the Rochester incidences. This is, God forbid anything like that ever happen in our community. There's always, stuff happens and God forbid that ever happens in our community. But I think I think we're ahead of the curve as far as the training and the programs that we have. But I also think that there's an opportunity to enhance those and grow and potentially prevent something like that from, put things in place now that even further prevent something like that from happening here. And as we know, and you're seeing it in Rochester now, we tend to have knee-jerk reactions to horrible situations. I think that there may be an opportunity to, put some further preventative things in place now in our system and our program. I mean, I'm not saying that Broome County and the Binghamton and the system that we have right now is perfect, but I will say that it's better than a lot of the things I've seen in other communities. And I will say that, I feel like our leadership in our communities are very progressive when it comes to thinking ahead and designing systems. And the system, the system that we have right now isn't perfect, but for whatever reason, it's being modeled across the country when you talk about 911 diversion and things like that. So we are in a good place, but we're in a place where we can take what we have to the next level.
The last thing for me is, what are you doing in regards to getting that message out? Because I think that's what some of the community's concerns are, is that the work that you all are doing and what's working for us and being a model and all, it's not information not disseminated to the rest of the public or to the people. So maybe there's something more that you all can do as far as PSA or something like that to get the information out, to try to divert some of their negative feelings about how the police are handling. Because I really am really proud of the police force here, the administrative that we're under right now. We took a proactive approach. I think we still have a lot of issues to work on as far as culture diversity. Dynamics of our community has changed now with more people coming in to our community and stuff. And I think that's something that with training and educating people in the community will kind of release some of the tension and restore some of the trust in the police department. And not so much what was just taking place on a national level. It's good that we had to look into this and do this. It was inevitable. But I think that, like you said, we're way ahead of the 8 ball in this perspective and things like that. We have a long ways to go. So I'm just glad to be a part of this committee. And I want to commend you all for the great work that you are doing. But I think in some way it needs to get out to the community that this is what's working. I've been really educated through coming to these meetings and learned a lot. So I appreciate your time and your efforts and everything that you're doing.
Yeah, we appreciate that, Mario. And it's one of those things that you learn about it if you're interested. That's a hard thing sometimes in the community. I know the mayor mentioned the press conference that we had over the summer to talk about the great things that we've done here in our community and showcase those. To the point where the city is been generous with providing additional funding to enhance those services. But it's one of those things that it's hard to advertise and showcase those things. They're all of the things that we talked about are available on the MHAST website. As far as the services that the Mental Health Association provides for our community, it's one of those things that you really don't learn about until you need it or you want to educate yourself. And that's sometimes really hard to do for, from the community perspective. But, the mayor's office has done a good job with enhancing this. The City of Binghamton Police Department has done a great job with making sure their officers have the education. And I can say from my own personal experience as a retired police officer, I did not know half of the community-based services that were in our own community until after I retired and started working for a nonprofit organization. So, and I look back saying, my gosh, I wish I would have known about that when I was on the street. So one of the things that we've done is making sure that we're educating the officers on what are the services that are available for the folks that you're seeing in the community. And one of those is the crisis respite house that the officers reach out to and utilize that as needed for our folks in the community.
So Mike and Alex, we're closing in on about an hour. I wanted to present a question to you. I think a lot of the discussion regarding a diversion of 911 calls, et cetera, and utilizing mental health professionals. Can you speak to or provide a little bit of a context with that? Even if there is a mental health professional on a call, to what degree does you still need a police officer involved, whether it's for the safety of the individual, for the mental health professional, et cetera? Can you just provide a little context on that?
Yeah, and very good question, Jared. And I think the best answer to that is not always. It depends is really the kind of the key answer in the situation. Our mobile crisis team responds without police officers numerous times throughout the day, where they'll get a call from an individual who's in crisis themselves. or they'll get a call from a family member who wishes that the welfare of their family member be checked. So our clinician actually does that completely on our own without involving law enforcement now. It really depends on the level of risk. And when, so right now the system that we have in place is 911 does this risk assessment. If it's a low risk where the person may have suicidal ideation, but they don't have a plan and they haven't gained the means, they can still transfer that call to a crisis call center, and the police don't even respond on those calls because the clinician on the, or the professional on the mental health professional on the end of that call can assess that person further and perhaps over time either de-escalate it or put a safety plan in place for that person over the phone. And as I mentioned earlier, a person with a mental illness is more likely to be a victim of a crime as opposed to commit the crime themselves. So, that is, one of the myths that we talk about with levels of dangerousness is that out of the 2,000 calls, you may hear of just a very, very small few, throughout any given year. And imagine multiplying that by however big the city of Rochester is, how many mental health calls they get, and we're discussing 2. Not commenting either way on the response or the actions of that, but that's 2 calls out of, and they're 5 or 6 times the size of the city of Binghamton Police Department. So imagine how many mental health calls happen there.
Any final questions for Sergeant Legis Williams or Mike Hatch?
Thank you.
Thank you very much, you guys.
Yep, as I stated, this will be recorded and available on the YouTube channel from the city of Binghamton. This will be a great educational tool. Thanks to the members of the steering committee. Councilman Burns, you have a question?
Yes. Can we get a copy of the slideshow? A link to it or something like that?
Yep, it'll be linked to the YouTube on YouTube. So what they presented will be shared on the screen. Okay. Everybody, thank you so much.
Thank you,
Thank
guys.
you.
Thank you.
Take care.
Have a good day.